Bismillahirrahmanirrahim. Now we are going to discuss the pharmacokinetics second part, that is the distribution step. So if you have any question regarding this lecture or the last lecture or upcoming lecture, you can simply type your question in the comment box, or you can ask me by the mail me the ask to the Kazmi@gmail.com. So I will try my best to answer as soon as possible. So just look at the pharmacokinetics whole idea. So in the last lecture I shown this animation. So intestine is here. So your drug is in the first way, it move in the your GIT tract. So then it absorbs into the blood vessel. So this is our first step. If it's intravenous, so it no need for the absorption. So the next step after the absorption is the distribution. Distribution means drug is going to distribute into all the body, because the drug only cannot reach the target tissue in one way, because our blood is going throughout the body, means our drug is also going throughout the body. So let's see, this drug is distributing throughout the body. It can be reached into actual target tissue. Other tissue also reaches another tissue where they cause the side effect in the liver, in the kidney. So target tissue perform the actual job, therapeutic effect. So and in the other tissues they cause the adverse effect, which you call also the side effect. In the liver, where they metabolize, and by the kidney they are going to be excreted. So we have two parts, pharmacokinetics and the pharmacodynamics. So pharmacokinetics involve the absorption, distribution, metabolism, excretion, while the pharmacodynamics is the therapeutic effect or the adverse effect or any action of drug which can do. So drug movement and the drug power. So now we are going to look at the distribution. So distribution, because drug has to, our concern is they perform the therapeutic effect, but they can reach throughout the body, and there it's not easier. So let's look at the distribution. How we can define it? We define it, it's a reversible step in which our drug transfer from one side to another side within the body. So it's a passive process between the blood and the extracellular compartment. So means your drug is moving between the blood and it can go to the extracellular volume. For example, here is blood, so it can go to the extracellular volume where they are found different tissues are present. So in this way, and they can go back here. So this is totally passive process, is dependent upon concentration gradient. If your concentration is more in the blood, it can go to the tissue. If it's more in the tissue, it can go back to the blood. So it is important for the onset, the intensity and the duration of your action. So because if it's remain in the blood for longer time, it can perform action for the longer time. It's because when it reaches at the specific concentration, it performs the job, we can say onset, then the intensity of the action. So it's totally dependent upon the distribution. So now if you look at the drug distribution, it's not distributed equally, as your blood is not distributing equally. Those organs which have more blood supply, mean they will take more drug, and the part which has poor vascular age, you can say, they have lower drug. Let's see what are those organs. For example, they initially rapid go into your well vascular age: liver, heart, lungs, brain, and kidney, while they delayed go to your poor vascular age: skeletal muscle, bone, and the fat. As you mentioned, it totally depends on the blood. So let's see what are the factors which actually affect your drug distribution. It depends upon the cardiac output, how much blood is going to a specific tissue. So cardiac output, plasma protein binding, cellular reservoir, and your volume of distribution and the tissue barrier. We have to discuss all these points. So first start from the cardiac output. If I ask you how much blood is going to your lungs, what is cardiac output towards the lungs? You may be thinking 100%, because your all the blood coming from the heart is going to liver, deoxygenated blood totally going to the your only one organ, that is the lungs. So that's why for the lungs it's 100%. So if we as is distributed, so if you look at the liver, 30% of your blood is going to your liver, because your GAT whole blood is via the portal circulation enter into the liver. So this 25% which is mentioned here for the gastrointestinal tract is also going to your liver. So overall 30% I think is the cardiac output is going to the liver. Mean drug is same in the same manner they are going to the distributing throughout the tissue. So skeletal muscle they have 25%, and your cerebral, you can say brain, and 5% is going to the coronary, mean heart, and cerebral mean brain. Okay, so it's very straightforward. So now let's look at the plasma protein binding. So it's reversible step in which drug transfer from one side to other. Plasma protein binding. So let's see, because your drug move in a bound form or free form. So if it's bound with the protein like this, it's reversible, as I mentioned. If it's bound, it is inactive form. If it's free form, that is your active form. So it can bound, not for permanent. It's a reversible step. Just remain the reversible step. So it can bound and it can go back to free form. Now, plasma protein, what are those plasma protein? You of course thinking the albumin, globulin, apoprotein, glycoprotein. But the major one is your albumin, because your more than 50% of plasma protein is the albumin, so your drug is bound to the albumin, simple. So globulin, apoprotein, glycose, especially for the this lipophilic, or you can say this steroid nature drug. Okay, now the next step, which is a tissue reservoir. Your many drug accumulate intercellular in the muscle, liver, and other cells. So it's depending upon the affinity is protein, phospholipid, and nucleoprotein. So these factor, protein, and the phospholipid, nucleoprotein, which is present in the cell, in the muscle, in the liver, so they actually take this drug, and your drug is bound with this component, protein, phospholipid, and nucleoprotein. So like this, for example, if you look at phenylcholine, which is anti-malaria drug, it's stored in the liver. It's several thousand times more than your plasma. Okay, so you can see how my drug is going to store in the liver. Now, phenobarbital, it's going to store in the fats. Tetracycline, heavy metal, they are stored on the bone crystal surface. And if you look at the toxic agent like lead, radium, and which is going to store in the bone. Okay. Now, the next step, that is volume of distribution. It's actually apparent volume. It's not actual volume. It's a amount of drug appear to be dispersed in the given blood concentration. No, it's confusing. A lot of students are confused. I'm just going to ask you a simple question. If you answer me, you will, inshallah, got this concept. Let's say if I ask you, I have 50 mg drug or solute. If I put into 1 liter, how much concentration I got? You of course thinking, if I put into this, so our concentration will be 50 mg per liter. And if this drug is going into 2 liter, what will be your concentration? Of course, because it's going to 2 liter, means it's going to become 25 mg per liter. So because your drug is going to distribute also into the blood volume, So this volume here is 2 liter. So we need to go think what are the volume where our drug has to go. So that's why this is apparent volume, which amount or dose of drug that is going to appear in the blood concentration. So our drug, where what are the spaces where drug can go. Let's see the example. I'm just going to recall your physiology, because if you are unable to understand that, it may be confusing. Let's suppose here is your blood vessel. Okay. So these are, for example, your different blood cells are moving in that cell. Okay. Now, out of this blood vessel, what is present? For example, here is different tissues are present here. Okay. Different tissues are present here. Now, let's suppose I send a drug like this. Our drug, first they can come into the plasma. So this is number one. You may be thinking it can come into this cell, so it can cross the membrane. The other way, it may cross this plasma membrane, come out of the plasma membrane and coming into this interstitial fluid. So this drug can enter into this tissue. So you can see, if this drug is only limited to the plasma, mean their volume is less. Oh, for example, 3 liter for the your plasma is present. So if this drug is coming out of the membrane, so it's limited for those drugs which are hydrophilic, they are larger molecular size, so they cannot come out of this blood vessel. So they remain in the plasma, so their volume of distribution is 3 liter. Other drug which can come out of the plasma, come into the interstitial fluid, so their volume of distribution is going to increase. These are hydrophilic but in smaller size. The other drug which can enter into the cell, because they can cross the membrane of the cell of blood cell, and they can also enter into the tissue. So their volume of distribution is going to increase more. So in this way, just apply this concept. So these are very lipophilic, and the smaller molecular, smaller size drug, they can enter into tissue. So the next thing, if you consider overall, for example, a 70 kg person, if you want to check the volume, if you check the fluid, it's 42 liter almost. So, but some drug you may see they have volume of distribution 2000, 1000. Is it possible? No. I have to check the drug concentration in the plasma, but my drug is going into the tissue where they bound. So it's not useful for me. So I only check the plasma concentration, how my drug is in the plasma. If it's bound, for example, if I give for example, if it's mentioned 2000 liter, the volume of distribution is 2000, it means your almost 1900 and almost 50 plus drug is going to bound into tissue. It's not present in the plasma or in any fluid. So that's why, according to this distribution, our drug volume of distribution is different for different drugs. Let's see the example. If it is a highly ionized, it's water soluble, so and high molecular weight, so it cannot cross a blood vessel, as I mentioned. So their volume of distribution is very low, only 3 liter only because it's plasma. If your drug is highly ionized, but low molecular weight, so some reach into the interstitial fluid, as I mentioned. So their volume of distribution is 40 liter, plasma plus the interstitial fluid. And if the other drug that is unionized and lipid soluble and molecular weight is low, so they can enter into the cell, so their volume of distribution is 42 liter. ECF is also, it's not a ISF, it's ECF. Okay, so the other drug which is unionized and low, but they are high affinity for the tissue, mean they're bound in the tissue, not moving in the tissue, they are bound in the tissue. So their volume of distribution will be more than the 42 liter. It's totally dependent upon the chemical composition of your drug. Okay, so let's check the volume of distribution, how we can check out. It's normally this is formula is applied volume of distribution amount over concentration at 0, but I think you use this thing, concentration amount per volume. For example, if you want to check out the amount is 50 mg, as I mentioned 50 mg, if the volume of distribution is 3 liters, so just easier, 50 over 3 liters over 3. In this way you can calculate your concentration. So we need to check out the different question. So why I mentioned the concentration at 0, because at 0 time, because it varies with the time. As you time pass, your drug is going to distribute in different tissue. Okay. Now what this tell, you can see the concentration is inversely related to volume of distribution, and it's directly related to dose. If you give more dose, your concentration is going to rise. If you give less dose, your concentration is going to decrease. Same thing if your volume of distribution is larger, means your concentration is less. Now this is, I think you should be covered this. Now the next thing is where this drug can distribute. Two important factors, that is blood-uterine barrier and blood-brain barrier. Uterine means your placenta, and you can say, and blood-brain barrier. So because only small and lipophilic, they can cross this barrier, and so we should be careful which drug we should give for the pregnant woman, which should avoid it. For example, heparin and warfarin. These are two examples, heparin and warfarin. Both are anticoagulant. What will be your choice? I give you some hint. It's a charge, it's a high molecular weight heparin, while the warfarin is small and lipophilic. Which anticoagulant you will prescribe to the pregnant woman? Of course, you thinking right, the heparin. Why heparin? Because heparin is a high molecular weight, it's a charge, it cannot go into the placenta, it don't affect the baby. So that's why our heparin is chosen in the pregnancy, causes no birth defect, because we don't need the anticoagulation or you can say bleeding in the baby. Okay, so same thing is happening, blood-brain barrier. So only small and lipophilic, as they go to placenta, it's, I think it should here should be mentioned brain. Okay, brain. Okay, so for example, PTU and methimazole. It's not what are these? These are for the hypothyroid patient. If you want to give a person who is has the PTU and methimazole, if it's a pregnant woman, what you should give? PTU or the methimazole? Let's see. 90% PTU is bound. 10% is your methimazole is bound. So if it's more bound form, means it's less of a free drug. So the less free is more safe as compared to the more free drug. If it's more free, means it's more active, it can cause the problem. It can go into your baby. So that's why a PTU is chasing the pregnancy, and so they cause no effect. Otherwise, if you give the methimazole, for example, it can go to the baby, where baby is not a hyperthyroid patient, so where they cause the cretinism, mean their brain is not developed properly. So we should be careful regarding all these concerns. Now, another challenging and the very practical question, that is the loading dose and your maintenance dose. So two doses. It's a Loading dose is actually a one big bolus which we initially give to quickly gain the plasma concentration of drug to a therapeutic level. While the maintenance dose, these are doses given which aim to maintain a therapeutic concentration of drug. So let's see with this graph, which I think it is more helpful. For example, here we go. On this side, drug concentration on this side, I'm showing the time in the 1, 2, 3, 4, 5, 6, 7. Okay, let's see. I'm going the intermediate doses. For example, if I give patient drug 100 mg, for example, what will happen after the first half-life? It go back to the 50. Now I give the second dose. Now the concentration reaches into 150. If it after half-life, what will happen? It go back to 75. Then I give the other 100. It reaches to the 175. Then go back to the 87.5. So this process continue. 187.5, 94, and no 194 and 97. 100. So eventually this process continues. Eventually what will happen? It reaches to 200, which and come back to the 100. So after this concentration will be more than the 100 in the plasma. So you can see, one is this process. I want the 200 mg concentration in the body. So one is this approach. Other is, so in this what you can see, if you see after the 4 and 5, I think your half-life, your drug is more than the 97%. Mean it's quite relevant, which I need. Okay, more than 97%. So that's why its steady state concentration is maintained. After this, because 200, 100, 200, 100. So this process continues. So after 3.3, you will see it's your steady state concentration has been more than the 90%. So if you see, if you have shorter half-life, it's rapidly reach the steady state concentration. If it's a larger half-life, it takes days and weeks to reach the steady state. Let's say if, for example, a drug has, in this case, has 1 hour. How many hours we need to take? For example, we need 5 hours to maintain the steady state concentration. If another drug which has, for example, whose half-life is 1 day, what will happen? Means you need 5 days to maintain the steady state concentration by the maintenance dose. Okay, so that's why if your half-life is longer, means it takes more days and weeks to maintain the steady state concentration. If it's shorter, it rapidly reaches the steady state concentration. Okay, I think this concept should be clear. Now let's compare with the loading dose. What will happen? For example, if I give patient, now let's look at the loading dose. What is happening in the loading dose? So in this case, you give a big bolus. For example, you have given 200 direct. As you give 200, what will happen next? It come back to the 100 after the first half-life. So then you give 100, it reaches 200, then go back to 100. So this story continues. So what you can observe here, you can see. So you can see first you have given 200 big bolus to maintain the actual this concentration. After this, you have just continued the maintenance dose of 100. So this first big bolus is actually considered as the loading dose. So first big bolus dose given initially to quickly get the plasma concentration of drug at the therapeutic level, that is the loading dose. So it's totally dependent on the volume of distribution. You just need to know the volume of distribution, and you need to know the target. So multiply the, for example, 3 liter in it, and in this case, for example, 2 liter. If it's a 2 liter or 3 liter, so simply multiply the loading dose. For the loading dose, simply multiply volume of distribution by the steady state concentration. So it's simple. So other way that is shown here is constant infusion, where you want to get the steady state concentration. So I think this is clear. So its volume of distribution is important for the loading dose, while in case of maintenance dose, you need to think of the clearance rate and the half-life, because half-life is affecting the maintenance dose, because if you need to, you can say, recharge that part which has been gone. Now I think this session is over. We meet with the next session. Thank you very much. If you have any question, you can simply comment with.